Assalamu alaikum. I would like to thank the organizing committee for inviting me to this conference. Today I will talk about hypertension in pregnancy. Before going there, just a few slides about obstetric medicine, or also known as a maternal medicine, high-risk pregnancy, or medical complication of pregnancy. It's a branch of medicine that care of pre-existing or newly discovered medical illnesses in a pregnancy. Our aim is to take care of pregnant women with medical conditions like diabetes, hypertension, to offer a preconception counseling and to optimizing a good health status prior to pregnancy. And we offer also to manage during labor, delivery, and postpartum care. So is obstetric medicine is important. This is a annually year done in UK of why pregnant women die in UK. And it shows that there is a decrease in mortality rate of pregnant women, direct and indirect cause. So we are doing a good job together with the obstetrician. Coming back to my lecture, today I will start with physiological changes of pregnancy, types of hypertension in pregnancy, how we differentiate between them and how we treat them. I will talk a little bit in more detail about preeclampsia, and I will end my topic talking about postpartum hypertension. Physiological changes, the primary changes in pregnancy is the vasodilation. There will be a fall in systemic vascular resistance, which will be compensated by increase in cardiac output. So the blood pressure will be decreased starting early in pregnancy till mid of 22 or 24 weeks. Then it will start to rise up again till it reaches its preterm level, its pre-pregnancy level before term. Why do you need to know these physiological changes? Because if the patient presents to you early in the first trimester with the normal blood pressure reading like 120, 130, we expected her blood pressure to be lower than that in the first trimester. So you should keep an eye on her and follow up her regularly. Hypertension in pregnancy, we define it as systolic blood pressure more than 140 or diastolic blood pressure more than 90 on 2 occasions 4 hourly apart, or 1 occasion of a blood pressure more than 160, 110. Some definition, they take in serious the rising of a blood pressure itself. So they define hypertension in a pregnancy as rising of systolic blood pressure more than 30 from the early pregnancy readings. But what we do actually in the clinic, we stick with the first definition. We don't have stage 1, stage 2 hypertension. We have mild, moderate, and severe hypertension. Mild hypertension, systolic range between 140 and 149. Moderate hypertension, blood pressure between 150 and 159. And the severe hypertension over more than 160 or diastolic more than 110. It's a quite common problem. Out of 800,000 births each year in UK, there is 10% of women will have hypertension in pregnancy. So at most, almost 80,000 patients will have hypertension in pregnancy. We classify the hypertension into 4 major types: chronic hypertension, gestational hypertension, preeclampsia, and superimposed preeclampsia. Why do we need to classify the patient? If you saw a patient in the OBD or they called you from the ward, you have to differentiate which type of hypertension she has. Because by this, you will pick up early the preeclampsia cases, and by classification, you will decide which type of a treatment you will choose, mode of administration, and how long should you follow up the patient. There is adverse outcome of a pregnancy, of hypertension on a pregnancy. There will be increased risk of superimposed preeclampsia, abruption of placenta, fetal growth restriction, and all these factors are a reason of heterogenic preterm delivery and its complication. So chronic hypertension, this is the patient having hypertension before getting pregnant. She's either diagnosed or not diagnosed, and it does not resolve after delivery. The frequency increased nowadays because of increased maternal age and increased rate of obesity. Gestational hypertension, or previously called pregnancy-induced hypertension, it's a new onset hypertension without proteinuria. It's usually coming after 20 weeks of gestation and resolved within 3 months after delivery, maximum 6 months. Preeclampsia or superimposed preeclampsia. This is diagnosed when the woman have chronic hypertension. She develop a worsening hypertension with proteinuria or with features of end organ damage. Example, like a patient with lupus nephritis or antiphospholipid syndrome. Preeclampsia, before we used to diagnose preeclampsia as having the triad of edema, proteinuria, and hypertension, but it's not anymore. Preeclampsia, it's a syndrome of new onset hypertension or worsening hypertension with or without proteinuria with end organ damage. It's most often coming after 20 weeks of gestation in a previously normotensive woman, and the incidence is 5% in US. So when we start antihypertensive, which antihypertensive medication we can use, there is no big trial of which drug is preferable on another drugs. All antihypertensive medication are crossing the placenta. Some data suggested that hypertension increased the incidence of congenital heart disease, and treated hypertension increasing this risk also by twofold. The choice of your drug depends on the acuity and the severity of hypertension and whether parenteral or oral will be used. Our goal is to minimize the maternal risk factor, cardiovascular and cerebrovascular effect. These are the usual medications that we use in pregnancy. It is a good antihypertensive, effective, and an acceptable safety. So starting to manage hypertension, if the patient, as we classified before, having a mild hypertension, blood pressure between 140 and 149, with only hypertension, no other risk factor, you don't treat. Just ask the patient to check her blood pressure 3 to 4 times a day and send for her labs twice a week, including RFT, liver function test, CBC, and proteinuria. If the patient has a moderate hypertension, blood pressure between 150 and 159, you can start oral treatment. Usually we start with first-line labetalol. And the same, ask the patient to check her blood pressure twice a week, 3 to 4 times a day, and send for her labs once a week. For severe hypertension, blood pressure more than 160 or diastolic more than 110, the patient should be admitted. And IV drug medication should be started to prevent the serious complication. If maximum dose of one agent is not effective, you can add a second and a third drug. You should closely monitor the patient, frequently send the lab, and fetal assessment should be done by the obstetrician. At any time, if there is any sign or symptoms of preeclampsia, delivery should be considered. Our target blood pressure is to bring down the blood pressure between 130 and 150. How rapid should I bring this blood pressure? It is controversial, but as we all know that aggressive decreasing of blood pressure predisposes the patient to ischemic and myocardial and brain infarction. So decreasing the mean arterial pressure by 25% of the original blood pressure over 2 hours is a reasonable one. You should avoid ACE inhibitor, ARB, direct renin inhibitor because they are causing a fetal renal abnormalities. You should avoid mineralocorticoid receptor antagonists like spironolactone because of their anti-androgenic activity. And you should avoid nitroprusside because in a small study they found the fetal cyanide poisoning. How do I follow up patient, a stable patient? Usually we will follow up every 4 weeks in the first trimester. Second trimester, every 3 weeks. From 30 weeks, we follow them every 2 weeks. And from 35, we follow them weekly. These labs should be sent every month. CBC, urine routine, albumin-creatinine ratio, ECG if the patient has a long-standing hypertension, Thyroid, TSH, because we are seeing a lot of patients with hypertension have associated hypo or hyperthyroidism. And if you suspected that a patient has a secondary causes of hypertension, you send for her all the investigation. In labor, you should continue the same antenatal hypertensive medication. You should keep the blood pressure below 150. You should measure the blood pressure hourly in mild or moderate hypertension and continuously in severely hypertension. When should I deliver the patient? Also, we don't have any trials about this. It's usually the decision of the obstetrician depends on many factors. For a breastfeeding mother, the breastfeeding itself does not increase the blood pressure in nursing mother. The medication we use early in the pregnancy, we can use it in the breastfeeding. Coming back to preeclampsia, because it is an important issue. Preeclampsia, as I said, it's not just a hypertension and a proteinuria. It is a multi-factor, it's a multi-system endothelial dysfunction that causes widespread effect. This is the pathophysiology of a preeclampsia. If the patient has one of the predisposing conditions, she's a primivirus or she's pregnant with the twins or triplet, her age is more than 40, she had a previous history of a preeclampsia or family history of a preeclampsia, she had a pregnancy interval of more than 10 years or she's obese, so she's predisposed to having a preeclampsia. There will be an impaired invasion of the maternal spiral artery leading to a defective in placentation, so resulting of release of cytokines and circulating factors. There will be increase in the thromboxane, decrease prostacyclin production, decrease level of a placental growth factor, and increase the production of angiogenic factor. All these factors will lead to disruption of abnormal pregnancy vasodilation, so leading to a systemic vascular and endothelial dysfunction and target organ damage, affecting the kidney, the liver, the coagulation, and the CNS, with a worsening of fetal outcome like a premature labor, IUGR, low birth weight, and perinatal mortality. Criteria to diagnose preeclampsia is either hypertension with a proteinuria or hypertension with signs and symptoms of end organ damage. Don't depend mainly on proteinuria. The NICE guidelines suggest that if the patient has 2 moderate risk factors of a preeclampsia or 1 high risk factor of a preeclampsia, you're supposed to start it for her baby aspirin starting from 12 weeks of gestation. And actually, we started early than 12 weeks. So treatment of severe hypertension in the preeclampsia. For mild and moderate hypertension in the preeclampsia, it's the same as the before hypertension, all types of hypertension. But for the severe hypertension in the preeclampsia, the definitive treatment is delivery. As long as the gravida remains undelivered, the mother is at risk of complication. The risk of these complications subsides in hour after delivery. If delivery it's most likely dependent on obstetrician. If they want to delay the delivery for a few days because of the fetal size, we believe that blood pressure should be maintained below 150. Oliguria, it's a normal feature of a preeclampsia, especially if they use syntocinon or induction of labor. You should not treat it with large volume of IV fluid. We prefer to keep the patient on the dehydrated side rather than overloaded the patient. If syntocinon is necessary, you can give it in its concentrated form. And don't use diuretic unless there is a sign of over fluid. Your job is not ending by delivery the patient and that's it. There is something called postpartum hypertension. The blood pressure peak up again from 3 to 6 days postpartum, and it may be higher than the antenatal period. This could be a new hypertension or persistence from the antepartum one. It is due to comorbid cofactors like administration of large volume of a fluid, patient who's having because of patient who are using non-steroidal or ergot derivatives, because of loss of gravida uterus and decompression of large arteries, so increasing the venous blood again. It's quite common. It accounts for 20% in women within 6 weeks of delivery. It's usually resolved spontaneously within a few weeks, and it's almost gone by 12 weeks. However, if the hypertension presented more than 6 months, you have to search for the causes of, maybe she has another secondary causes of hypertension, and you should start her on medication. Risk factor for this patient, postpartum hypertension, is high PMI or history of diabetes. In the postpartum, you also still have a chance of getting preeclampsia or HELLP syndrome, so you have to take care of that. Long-term prognosis. Risk for developing hypertension is twice in women with hypertension disorder. This is 1 year post-delivery. And the risk of developing chronic hypertension will increase 4-fold in women with history of mild preeclampsia. The risk increasing 6-fold in women with severe preeclampsia. The risk of ischemic heart disease is higher in severe preeclampsia patient, and the absolute risk of any cardiovascular complication is high for non-preeclampsia group. There is increased risk of coronary artery calcification in patients present with history of preeclampsia. So, just to summarize, hypertension is a common medical problem in pregnancy. Treatment is indicated if the patient has a severe hypertension, blood pressure more than 160/110, if the patient has a mild or moderate complicated hypertension, and if the patient has a preeclampsia. Our treatment is to bring the systolic blood pressure between 130 and 150. There is no proven maternal or fetal outcome in treating the mild hypertension cases. What we use is these agents, which are safe and good antihypertensive effects. ACE, ARB, and direct renin inhibitors, they are all contraindicated in all stages of pregnancy. Preeclampsia is more than just hypertension and proteinuria. It is a multi-system endothelial dysfunction. Daily aspirin dose could lower the preeclampsia risk, and it is recommended in all pregnant women with hypertension. Oliguria is normal feature of preeclampsia, so you can't just wait and don't send for a nephro consultation. Postpartum hypertension is common. It is multifactorial, and you still have a risk of developing preeclampsia in postpartum. Preeclampsia remain a common direct cause of maternity death, and its cause account for 5% in all pregnancy. Delivery is the only cure for severe preeclampsia. And thank you.